Hello everybody, this is Jorge Campos from Vigo, Spain. I just want to thank you to stay here with me on a Saturday afternoon here in Europe time. I hope that in America is very early, perhaps in the morning on the west side. So let's begin with my conference, the lecture about socket shield failures and classification and treatment options that we have. So, good luck to everybody. Let's start. Okay.
No, en vez de...
Aquí. Transition. Aquí. Okay, ahora yes. So, I want to thank you to the Canadian Network organization for helping us in this broadcast, especially to my friend Mark Bishara. Okay, we have today socket shield failures. First of all, I want to dedicate this conference to the PET research group. That is a group that we have pushing and working together the last few years on this field. And this that you can see on the screen, there are the experts worldwide. So to them, maybe some of them are present, to them I dedicate this conference. Also, I want to mention that last year, after 4 years or 5, after the PET treatment became something very common, unusual, we gathered together at Madrid on the first PET consensus. And we also published the consensus, and they were all in together, and we gather, and we have a coincidence that how to practice all the socket shield and treatment options. So let's begin. If we are going about failures, we have to say that every technique, every treatment that we do on our office has failures, because it's not 100% perfect. They are not. They always something happens. So, but we have to understand what failure means in this case. So, I've been practicing socket shield since the past 4 or 5 years now. So I have some experience about what can happen and what happened to me. Today I want to present the most important failures that I had practicing this technique. So how can we classify them? So my idea is to classify from like early failures and late failures, saying that the definitive prosthesis is the timeline that separates the both failures. So there is a dark side of the socket shield. Yes, there is. But we have to see which is, and how is, and when. So the failures that we are talking about are the shield loosening, the external exposure, the internal exposure, and osseointegration failure. And we can classify them as early and late. So let's talk about the early case of an early shield loosening. This is a patient of mine that I practice a socket shield on the lower canines. You can see here, one side, the other, and showing here that there is bone outside the shield, and 3 months later it healed perfectly, not even exposure here, even though she wore a complete denture. But when I uncovered, look what I saw. This is how it was at the beginning, before the implant placement, and this is at 3 months. Look at this. There is bone, perfect shape, and this is the shield that is loose. So I was completely astonished. It was my first time that happened to me, and also showed to my team to understand what happened here. Look at this, how much bones we have lost in both sides. Also, it was loose and it was a defect, but fortunately it was there has two big walls, and the implant is inside the bone frame. So it was very easy to regenerate, to do a guided bone regeneration, and to close, to put some PRF. And on the left side, it's also happened the same. First of all, I tried to trim, as you can see here, but after trimming, the shield became loose, and so it fell down. Also, I did a bone regeneration and put some PRF, and after a month, this is the results. After 45 days, you can see that I managed well the situation, because I have a good keratinized gingiva at 3 months and 1 year and a half. The patient is comfortable and the side is with good keratinized gingiva. So it was a failure, yes it was, but could be managed. Second class failure, a late failure. This is, in my opinion, worst. And I want to show you an example. A socket shield that was for me one of my best on the aesthetic area. The shield was, the intention was to preserve this little bone that was there. And I did it on July 2014. But unfortunately, 2 years later, 2 years and 2 months later, the patient appeared with the shield on the zenith of the crown. So it was loose. So I have decided to remove it. And this is important. I made an incision. You can see, I want to show you the incision that I made, and remove the shield. Then I have to prepare this part. I took some connective tissue graft from palate. I put autologous bone, lip bone over the threads of the implant, allograft, a sandwich of membrane, the connective tissue graft, and PRF, all packed here and sutured. After 2 months, you can see the result, and it was not a disaster. And here we can see that after 1 year we have almost a nice solution. We were planning to extract these teeth, but we did the socket shield. Now the problem was that the shield came loose after 2 years. So in my experience, this is not common, because you can see that I only have these cases, 2 cases of early shield loosening out of 169 cases, and 1 late case of 169. So this is not a very frequent failure. But most failures are combined, and I want to show you here an osseointegration failure plus external exposure. This was an immediate load case on the upper maxilla, and I decided to do socket shield on the front teeth, and I did in August 2015. And it was a success for only 89 days, because it was a failure at the 90 day. At 90 days, this in my whole career, it never happened. It was the first time that a immediate load that lasts more than 2 months ended with a failure. But it happened. The patients had kidney problems and many things that I still cannot understand why, but suddenly I had to remove all the implants. And there were 6. Not 4. It was not an all on 4. It were all on 6 long implants, but I had to remove it. So I decided to remove it and to clean on the same appointment with povidone and antibiotic, lincomycin, and fill with allograft. As you can see here, with a probe we are putting the povidone inside the sockets. And after 2 months healing, we can see that there is a little exposure of the shields, but after 4 months, the exposure of the shields are notable. You can see here. Okay, when I decided to re-enter and insert more implants, I noticed this. Please pay attention, that when we expose the shields, there is a bone loss on buccal, and I remember that when I first did they were bone level trimmed. You see? So there is a clear recession and bone resorption on buccal of these socket shields. But if it is there still bone to preserve, I will use again the socket shield. I will reshape them to make it flush with bone. The root submerged technique, roots submerged are still there and still alive. So I decide to insert more implants on the same places, on the same socket shields. And this time I did not did immediate load, just closed and did a submerged. After 6 months, I reopened again, and look at this, the probing depth, because I usually try to probe how much connective tissue invasion do we have between the shield and the neck of the implant, and it's almost like 3 millimeters. This is for me the normal, and it usually happens. Here is the way we test it. There are some shields that we remodel before closing, and you can see here that there is bone well preserved now, the implants, and from this situation we put some healing screws, and then we have what we love is to see the bone that keratinizes gingiva, a nice emergency profile, and we end with a nice prosthesis with a good bone protection of our implants in the front area, as you can see here. Okay, but if we talk about early external exposure, I want to show this case in a lower mandible, where our goal is to preserve this part. This is our treasure. You can see the keratinized gingiva around our lower incisors. So we trim our teeth. We extract this one because it had infection, and we did socket shield, and this side was compromised, and in the future this implant would not get osseointegrated. After 1 week, the healing is nice. After 12 weeks, you can see there is some implant exposure, some shield exposure here and there. You can see. How do we treat this? Here with a long incision, we open and trim to get the shield flush with bone, and then we suture, and the healing is perfect. We cannot see anymore any scar on the keratinized gingiva. And on the left side, you can see that we do a vertical incision. We open a flap, small flap, we trim all those shields that protrude, and after we suture, and the healing is nice again and perfect. So we have here the difference before and after, but we have maintained what we want, that is the keratinized gingiva. I want to show this. Look at the back part, the posterior part of the mandible. How much resorption do we have on the ridge because of the extractions? You can see there is a very, very thin line. So I love the way the PET therapies protects and maintains the alveolar bone around our implants, and most of all, I love the way the keratinized gingiva is maintained. Okay, because when we lose the alveolar bone, we lose the keratinized gingiva. So in this prosthesis, we have two zones. One with a clear arrow, that is the keratinized gingiva, and the other is a soft mucosa. This soft mucosa is weak and it can be contaminated, and the implant is not protected by this mucosa. Only this part is perfectly well and can be maintained. Okay, let's talk about inner exposures. I want to show you an early clear inner exposure. There was a man that had a breach, and the man came, he lost the breach, he was uncemented, 6 months, and he came, he's a sailor, he came out of the sea, and he said, I want to cement it back. And I said, it's not possible. Look at this. Here we have some periapical problems on both roots, and it was the conduct was completely decayed. The posts were not possible to, not even to use these teeth to do a new post and new bridge. So we decided to do implants and socket shield, as you can see here. And after 4 months, in this case, because I grafted and I did an apicoectomy, I also grafted between the shield and the implant. And after 4 months, you can see. But look at the different gap sizes that we have, and we have a good feeling on both sides. But we had at the beginning an inner exposure that could be treated directly. Inner exposures can be treated directly. Trimming with a diamond burr, a ball, a little diamond ball, can be treated like this, and we let bleed, so we will have this kind of closing. The connective tissue is going over the clot, and the epithelium closes everything. And this is almost the end of the story, and you can see a nice shape of the gingiva. Here we have a pontic. We prepared the site for this pontic. Look at the case before. And this is what we are working for, this band of nice keratinized tissue. Okay. But I want to show you a special case that is an internal shield exposure. As you can see here, this is one of my first cases of socket shield. It's a canine, upper canine. I did it immediate load. This was done in 2014. This is the whole case. In this part, on the bicuspid and these molar roots, I extracted and I had a lot of resorption. But here I did the socket shield and it maintained well. 3 years later, you can see that the result is very pleasing. The keratinized gingiva with its maintained. There are also better papillas than originally. But I want to show you that, and look at this profile. This is I think the best case for doing a socket shield, because the profile here is so convex that when you extract the root, you get a depression that you cannot hide it. You have to graft a lot just to discompensate. Here you can see the shield, the bone, but look at this. We see that there is contact here. Here we can don't notice, but we see that there is contact. It was contact at the beginning and at the end. Howie Gluckman, when we were talking about Dental XP Forum, we were talking, and he was the one, for me it's peculiar, because he was the first one who told me to notice that the space between the shield and the prosthetic restoration is the most important prosthetic part to avoid the shield exposure. If there is contact or proximity between the prosthetic part and the shield, gingiva won't lie over. So this situation, I kept it because it was one of my first, but I am following the case, and it has been 3 years and there is still no problem. So, as a resume, we can say that external exposure for me is very frequently. The reason, the cause, is the denture pressure, and the treatment is our mucogingival surgery. But instead, the internal exposure is very rare, not common, and the cause is something about technique, that we have to design better the prosthetic space. Okay, we can say that external and internal, the same reason, no, are completely different reasons, completely different treatments, and completely different frequencies in my practice. But these failures, I would say that they are just complications, because I resolve them very easily. But please, I want you to pay attention, because what we did at the beginning, and I remember at this time to my friend Chuck Schwimmer, that at the beginning we did this. That is, there is an external exposure, no problem. You can trim easily with a little anesthesia, but this is wrong, because it left a scar. You see, when you trim, you are making a scar in the keratinized gingiva that don't heal perfectly, and we don't want this. What do we have to do? As it follows. I want to show you this case where we did here 3 socket shields and 1 corticotomy, connective tissue graft in this part to fill this place. And after 4 months, we can see here that there is a little external exposure. You can see here. So the treatment incision is very important. We have to do a straight incision and horizontal incision to raise a mini flap and trim flush with the bone. With here we make a suture, 6.0 sutures, And this is the healing. You can see that there are no scars here, and this is the final result. So whenever we have an external exposure, please avoid the temptation of getting diamond burr and trim this little corner that appears. No. Just raise a mini flap and do the trimming. You can see the case after 1 year. Look at how beautiful is the gingiva. How nice the keratinized gingiva. The color, the shape, the texture. And also the bone in between. This is very interesting. Look at after 1 year, you can see from February 2016 to February 2017, the bone is still there in between the implants. I want to show another case, another front bridge that we changed from roots to implants, and we can use the canines to do socket shield. But on the upper right canine, this is a mirror image, you can see that is an exposition of the shield. This is due to the prosthesis that the patient wore. So I'm showing here that where is the implant and where is the shield. Okay, as I say, a vertical incision and horizontal incision. We'll raise a mini flap just to see, to expose the edge of the shield. And then we trim the shield flush with the bone, and there is soft tissue in between the implant, the shield, and here the bone. And we insert here PRF. We did punches on the other implants just to uncover, and we reuse this connective tissue graft on the punch to insert it here, as you can see here, to give a little volume. And after 14 days, you can see that it's healing nice. And after a month, the restitutio ad integrum is completely healed, completely perfectly managed the keratinized gingiva without any scar. I want to show you another failure that is we are ending now we are talking about osseointegration failures. Look at this case. This patient has lost this central incisor, then tooth number 9 in American nomination, but it's a upper left incisor, and this is fixed with composite resin, and you can see the depression that we have here because we have no volume at all. So I decided to do socket shield on the 3 of them, and on the pontic place I did a double connective tissue graft harvested with the Zucchelli technique. So I deepithelized them and inserted here, and we use a removable prosthesis. But after 5 months, when we want to uncover, we can see an implant that is not integrated, is loose. So we remove it, and we thought that how much connective tissue invasion do we have between shield and implant? And the other implants were perfectly osseointegrated. So we decided to do the bridge with those 2 implants, a 4-unit bridge with 2 implants, 2 very long implants. So we managed and we did the. Here it was a socket shield, now is a Pontic shield because we left the shield inside. Here we left the shield to maintain the buccal zone perfect and the keratinized gingiva. And socket shield, connective tissue graft, and socket shield. This is the final result with the Pontic shield, the socket shield here and there, and the connective tissue graft. The worst part is the connective tissue graft. It's not 100%, it's 85% of the volume that we needed. So, if we want to do some statistics, I want to tell you that the shield loosening is 2 out of no, here's a mistake. 169. So there is 1.1%, and the late shield loosening occur only one time, that is 0.55%. Internal exposure, I only had 3 out of 169, so is 1.7%. And osseointegration failures, I had 12 out to 169, that is 7%. So this is important, is not important, is representative. Oh, I was lucky because last year on October of 2017, Dr. Howard Gluckman, Maurice Halama, and Jonathan Dutoit published an original article about a retrospective evaluation of 128 socket shield cases in the aesthetic zone and posterior side. And they share with us some failures that they had. So it was very interesting to compare their result with mine. So mine early shield loosening and the late shield loosening, it was more or less a little bit lower than their shield loosening. They report 3 out of 128. Okay. And about integration failures. So they had only 5 cases of 128, but I had a lot more, 12 cases out of 169. So if we compare, they have 3.90% of failures, and I had 7% failures. But we have to remember that I have 5 cases in my immediate load. So in just one patient, 5 cases. If I take this patient out of the statistic, I will end like 473%. But this is not unusual for me because I do not have in my practice, in my private practice, 98% of successful of osseointegration. No, this I don't. Why not? Because I do not select my cases. I just practice when my patient is willing to have an implant. Even if he smokes, even if he's diabetic, even if he has blood problems or had cancer or some, I use these patients and I put the implants. If I fail, I put it again, and always on the second or the third time I got a success. So this is, according to my practice, the kind of patient that I have, because in Spain, more than 50% of the population used to smoke, So you cannot say, no, I cannot use this patient. No, I practice with the local people. So my internal exposures were very, very low because from the very beginning, when we discussed at the Dental XP forum, Howie told me clearly what happened, what was the reason. So I always avoided to put my healing abutments, also the tailored the special adapted healing abutments to put it very far away from the shield. And also I internal bevel it since 2014. But internal exposure of Salama, Gluckman, and Dutoit, they are higher than the external. In my case, you see, there is just the opposite. And what was the reason? I thought that they only present cases of one implant cases in the aesthetic zone, and I said, okay, they do not have external exposure, because if they have a provisional, there is a very small and protects the external shield. But talking with Howie, he told me that no, they include in this case cases of the posterior zone and covered with full dentures. Okay, so this is the difference between my cases of the whole mouth are like this, and not only in the anterior zones. My conclusions: shield loosening is a rare phenomenon, 1% and 0.55% on the late cases. So external exposure, no, this is common on complete cases, and this is our new mucogingival surgery. So when we do two-phase implant, we have to do mucogingival surgery, apical advanced flaps. And now, when we do socket shield, we have to be prepared to do the rise, the flap that I showed to you with the incision that I designed, just to trim and to put the shield flush with the bone, just to avoid it happening again. Internal exposure. This is prosthesis related, and the more and the quicker that we learn this, as you can see here, the quicker we will learn to avoid this, and it won't happen to us again. The osseointegration failures, some as no PET cases in my practice. So all the problems that I have found are, first of all, easy to solve. They are just complications and not related to socket shield. I want to do a special thanks to my friend Mark Bishara, who made this possible, this broadcast possible. And I want to tell you, to all of my friends experts, that I want to share this statement of Niels Bohr, a Physics Nobel Prize. An expert is someone that has made all the mistakes which can be made on a very narrow field. So, dear friends, I think that we made it all. There are no more mistakes that we have been practicing and dealing with on the last 5 years with all our PET research group. So please, be happy and try and make any questions you want, because I'm here to answer. Okay. Here we have some questions, and I want to answer them. Please.
No hay, por ahora.
Oh, there are no questions, not yet.
Hay comentarios.
Commentaries.
Amazing. Thanks for sharing.
Ruth Delicapine, she likes my statistics. Mark Bishara. Nice. Okay, give my regards to Ignacio. Hi, Nacho.
Luis Besa antes estuvo.
And Luis Besa also, they was there.
Steve Mason.
Steve Major also, and all the Orlando group, and all my friends from Portugal and all over the world.
Are you grafting the gaps?
Mark Bishara is asking me if I'm grafting the gap. Usually I do not. I did it in some cases, and I did it with beta TCP. With usually I did with allograft, but normally I don't do it anymore. This is I found it not necessary. Howie Gluckman, he always does. He feels it's important. But I just want to tell you that even if you graft, there is soft tissue invasion in between the particles that you graft. Those particles does not promote bone. So I found it unnecessary. Hi Udata, how are you? Thank you for your compliments. Okay, as I said, it's going to be very, very clear, and there are very, very few questions because the statistics is very common and very similar to our friends.
Here we have 2 questions.
And you there they go. You place the over the ponte. Yeah. There is a question about when I cover a pontic shield with a connective tissue graft or a root submersion technique, and says where is coming all the blood supply from the surroundings. Usually, I don't cover the root submerged with connective tissue graft. I found it not necessary, which I just use PRF alone. In 95% of the cases, it covers easily and by themselves. If and the 5% that we need, we can do a connective tissue graft, but not at the first intention. It's easier, quicker, and better for our patient. But I learned how to do the root submersion technique, because this you cannot left flush with bone. You have to trim 2 millimeters below bone just to get I wouldn't say bone formation, but you can assure that you have connective tissue formation over your root. If not, it will be exposed. Do you prefer? Yeah, as I answer, I prefer to cover with PRF. Do you perform full root submersion? Yes, of course I do. Yes, it's the most interesting technique to do it.
Did you evaluate?
If I evaluate how much change can be even if I graft or I don't graft, I don't think that there is movement of the shield. Maybe in 10,000 socket shield there is 1 or 2 movements documented, or 3, but this is nothing that we have to be worried about. And if it's moved, it moves very, very little. So the graft won't help. Don't graft just to avoid this. This is nonsense. Approximately what percentage of my pet cases do I do immediate provisionalization? Maybe 20%, 20, between 20 and 30%. Why? Because it's very expensive in Spain just to do a provisional, screwed provisional. So the people prefer a removable prosthesis. And I feel comfortable in two phases, because two-phase surgery, just to manage well and perfect the tissues. No, hay una pregunta.
Jorge.
It's a matter of theory or no, Armando, hi. My experience, it's a matter of prosthetic about areas in mandibular, for example, mandibular versus maxillary. That shield moves. I repeat, I don't think the shield moves. Maybe you can find the case that moves, but it's not, for me, I haven't seen. Never. And there is no reason for the move, because you left the root attached to the bone. To have a movement, you need some force, and so I don't believe there is a movement. Maybe you can record it, but maybe it's a luxation of the shield, not also movement alone. If I perform pontic shield in roots with periapical radiolucency, even if you yes, when you have a radiolucency on the apical zone, you need to do an apicoectomy. I think I did the first socket shield with apicoectomy simultaneously, and it's a practice that we can do. We can see everywhere, and nowadays it's very normal, and there is very sure and very easy to do. It's a protocol that is very easy. Please see some cases that you do an horizontal incision, and you trim the apex, you clean it, and you can see through the window the apex of your implant. This is a nice picture to do. So it's very common and secure. So if you have doubts, please do it. But if you have doubts, you cannot do a root submersion technique, because you are leaving there something that is pathologic. If I tried socket shield in posterior mandible or maxilla, yes, I did. I'm not an expert. I do it regularly whenever I can. But the friends that they have done more than me is Chuck Schwimmer and from the United States, and Armando Ponzi from Italy. But I have done many cases. Nowadays, with the Densa burrs, I used to do a lot, because I left the shields on buccal, and I used the bone, interradicular bone, just to raise the sinus, to do a sinus lift, and it's very common and easy. It's a nice practice. Takes a lot of time. Yes, it takes. How to decide to go grafting the gap or not? I repeat, I do not graft. If I am doing an apicoectomy and I am grafting, perhaps if I have more, I prepare more than I can use on the apex, I insert it between the shield, but it's not necessary. Okay, it won't make a bad thing, but you don't need it, because you have to remember that the connective tissue will invade the neck of our implant, the coronal part of the shield. I said that this 2 years ago or 3 years ago, when the Mitzias Mitziadis came with the first human histologic evidence of socket shield. What did he show to us? That there was 3 millimeters or 4 of soft tissue invasion between the shield and the implant. And if we think that it's always, when we do an immediate implant, when we extract the root and we insert the implant, there is always on the coronal part of our implant, there is no bone. It's only connective tissue. And you can see on the histology of Dr. Tarnow, the famous histology with a big jumping gap. So what he showed, more than 4 millimeters of connective tissue invasion. Yes. There is Mark Vishara. Some clinicians may be afraid to perform vital root submersions from fear of infection. What is your thought on this versus Pontic shield? No. When you cut the root, if the root is alive, you see that it's bleeding, it won't get infected. This I tell straight to my students, and I gave this example. If you have my finger here and I cut my finger and the point, it's bleeding, and I said, does my finger die? And I say, no. Why not? Because you have blood supplies. Okay? And the same happens to our roots. When you cut the roots, there is an exposure of the nerve, the pulp, but this makes a coagulum that gets in contact very quickly with connective tissue. So it continues alive. The nerve does not die, the pulp does not die. And do you say, it gets infected? No, it won't get infected. This is not possible, because for getting infection you need more time. When you have a cavity that slowly stays for 3 months or 2 years getting to the nerve between inside the tubule or dentinal tubules, yes, they get finally, but they have been exposed many years or months. But here is 1 second you cut, and after a few minutes, you close it, everything, and the environment is completely closed. If not, you would say that all the alveolus will get, all the socket will be contaminated, okay, get infected because they are exposed. So don't worry. And there are many studies on the 1960s that show that the tooth that you cut, the pulp is still alive. Okay. If I perform root submersions in root canal treated teeth, yes, I do. If I worry about apical lesions developing later on, no. If there is no lesion at the beginning, that I am not worried. If there is lesion at the beginning, you do an apicoectomy simultaneously. Yes, this is, you mean the shield move because you will probably luxated? Yes, I'm afraid. Yes, this is the only reason that I feel that you can have a movement of the shield. Because think about, the shield is completely attached by periodontum, by PDL to the bone. So why will it move? If the root is completely there, 100%, it doesn't move. If you cut 50%, it doesn't move. If you trim, perhaps if you insert the implant, perhaps you are luxating the shield. But because it is pressed by the coagulum, by the implant, it will heal in this position and it won't move. Within the human which is the technique that I used with the densa burrs. For example, I used always the Charles Chuck Schwimmer, that is here. Hi Chuck. He uses a nice protocol that you can look at the site on Facebook that the name is Spot, that is Site Preservation of Tissues. His protocol of cutting the root with the densaburs on the clockwise direction. But I use a different protocol. I just get away from the shield, and I use the burrs just to also densify the site if I need it. Okay. Snejana asks if I ever tried to left submerged root not covered with PRF or connective tissue graft, just coagulum. And I said no. The answer is yes, but I did a first intention a flap that it closes perfectly, a first intention, not open. And so in these cases, but usually if it's only one root and I have a socket here, a socket there, I just use PRF always, because I always have PRF when I do surgeries. If a tooth has been under function and it is moved from function, don't you believe the PDL will respond in some way? No. Good question, Charles. Good question, but I got the answer. He asked if a tooth has function and suddenly it has no function. Which is the response of the PDL? I will tell you. The response is none. What happens? The bone gets poor. You know, there is a nice, this I used to teach, when you do it on monkeys, that you cut or for example, you get the opposite molars of the mandible, and what happened with the bone on the upper jaw? It gets poorer and poorer because it does not bite anymore. But the tooth extrudes very, very, very slowly. But the most important and relevant part is that there is no transmission of forces to the bone through PDL. So we see that the trabecula is getting poor, more clear. There is not dense anymore. And on the opposite side, when the molar is working, we can see that it's normal function and normal trabecular zone, but the PDL is comfortable without working. Have you tried modifying a socket shield technology? Oh, here in our group, everybody has tried to modify the socket shield technique. For example, at the beginning, Hursel's technique is to use the root canal and to enhance the root canal with the implant burrs, and when they get very thin, they remove the lingual part. We don't do this since 2013. I don't do this anymore. I never done this way. I only I cut mesiodistally and remove the lingual part, the palatal part, and then I prepare the vertical cut flush with the bone, and then the internal part I make a slice. I bevel it internally just to put it away from the prosthetic zone, the prosthetic compartment. So, and what was the modification? For example, the C. My thought was, is it important to maintain the vascularity? Yes. And which is the weakest part? The buccal and the interproximal. So, what I did, I left part of the shield like J or C when you take the two peaks, the mesial and distal peak zones. Just why? Because I want to maintain the papilla. So we need to have the peak bone, the interproximal height bone. We finished. I want to say that. Happy good Saturday night from Vigo. Bye, my friends. Bye, Mark. Thank you for inviting me. It was a great honor. Bye bye.
Stop streaming.